San Antonio to help UT Health San Antonio to help develop sports medicine fellowship. Currently, Dr. Svec is the medical director for primary care center sports medicine and assistant team physician for UTSA athletics.
All right. Hello, everyone. So, yep, as Dr. Nato said, it wasn't too long ago, at least in my opinion, that I was sitting where a lot of y'all are sitting today. And so always happy to come back and talk. So today we're going to talk about sports-related concussion management. There are, concussions that you can get from other injuries, but my focus is typically on sports. And I'm going to give some insights from the Amsterdam Consensus Statement, and we'll go over what that is shortly. So objectives today: understand the latest advancements and updates in sports-related concussion, as outlined by the consensus statement. We'll learn some of the best practices for accurate diagnosis and assessment, and gain insight into some of the treatment plans and, whole body recovery strategies that we use to promote athletes' health and safety. So first, we'll start with a basic introduction of what concussions are. So it's a mild traumatic brain injury caused by a blow or jolt to the head or body that disrupts normal brain function. And so typically, and y'all see a very long symptom list in a little bit, but headache, dizziness, confusion, sensitivity to light, those are a lot of the things that people typically associate with concussions. What can cause this? Sports injuries, which I've bolded since that'll be our focus today, falls, accidents, violent impacts. The duration of concussions can vary. Most resolve within a few weeks, though, with the proper management. Some do require prolonged care. So specifically, sports-related concussions, there's a high rate of these in contact sports. So in Texas, that's primarily, football, soccer. I don't think we have a large hockey and rugby population. They can happen in other sports, basketball. I've actually seen some baseball players, just depending on what happens. And so, but, football, I think, is where mostly we think about it here. The risk factors for this: repeated impacts, high intensity play, lack of protective equipment. Consequences: so you do have, the short-term effects, impaired cognitive function, long-term risk, definitely in the news more frequently now, repeated concussions causing CTE, chronic traumatic encephalopathy, or a persistent post-concussion syndrome. Effective concussion management is crucial for preventing some of those long-term effects and also making sure that the athletes go back to play safely. So what's the Amsterdam Consensus Statement? So this is a set of guidelines that they put out, I don't know, every so many years, but the most recent update was in 2023, and primarily they met in Amsterdam. The COVID pandemic did affect it some, so there was a slight delay there. But this provides updated evidence-based recommendations for diagnosis, management, return to play protocols for sports-related concussions. And this includes a large panel of experts, including researchers and clinicians specializing in concussion and brain injury. A large they focused it on the R's of concussion management. So if you pull up the whole statement and read it, you'll notice that it's broken down by the R's. So I broke down my presentation by the R's. So these are all of them, and we'll go through them kind of one at a time. First one is probably my least favorite slide. It's a really long definition. So this is recognized. So I gave you kind of like my brief definition of concussion a couple slides back. This was the larger one that they made. I'm not going to read it, but it is in my slides. And I just wanted to make sure we didn't skip any of the R's. So this is recognized. And then it gets a little bit more digestible. So second is reduce. And so they highlighted areas where we could make interventions to reduce the prevalence of concussions. So policies, personal protective equipment, training strategies, and concussion management. So some of the things they highlighted in policies is changing what's is allowed in certain sports. So for example, they found a study that talked about how a body checking ban in youth ice hockey cut concussion in games by 58%. And so the thought is, do we really need to allow body checking in youth hockey? Probably not. And that could prolong their ability to play hockey later on in their life. Another example, limits on contact practices and collision time in American football led to 64% reduction in practice-related concussions and lower head impact rates. So again, do we need to have so many collisions in practice? Maybe not. And it did result in a significant reduction in concussions that happen in practice. Personal protective equipment. So mouth guards in ice hockey reduced concussions by 28%, suggesting that they should possibly be mandatory for all levels. Training strategy. So regular participation in neuromuscular training warm-up programs, at least 3 times a week is what they defined as regular. Linked to reduced concussion rates in the rugby union. This one, however, they said they did give the caveat that maybe they can't apply this to every sport. And neuromuscular training is training that focuses kind of like on neck stability, things that would prevent the head from jostling around too much. Concussion management. Effective concussion management, including removal from play, making it mandatory, medical clearance for return, and education on symptoms also help reduce concussion rates. So making sure that you do have a good policy in place. And so, for example, I spend a lot of my time taking care of UTSA athletics, and we have a team policy for concussions at UTSA. When the athletic trainers step in, when the doctors step in, how we progress through return to play, how many appointments that is. We keep great documentation of it because we are trying to make sure that we protect the athletes there. Then the next R, we have remove. So this goes along with some of the strategies in reduce. So remove from play if a concussion is suspected. Signs for immediate removal include confusion, poor balance, loss of consciousness. Players exhibiting the symptoms should not return to play until thoroughly evaluated by a healthcare professional. I did want to note here that if it's a sideline that's being covered by an experienced athletic trainer, they're likely to make this decision. And so it's at the higher levels of play, there's athletic trainers for each sport. In the high school, you know, there is typically an athletic trainer that covers the whole school. They are able to do that sideline screening and, you know, just involve the physician if they feel it's necessary. One of the things that helps them make that decision is called the SCAT-6. Prior to the Amsterdam Consensus Statement, it was a SCAT-5. So now they've updated it, so it's the SCAT-6. And that's the Sport Concussion Assessment Tool. I broke it up into slides, but it is a lot of words. So I just kind of wanted to make sure people were familiar with it, but maybe not go through every small detail that's on these. And so this is the immediate screen. And so you look for the red flags, which I included the box next to it. So neck pain, tenderness, seizure, convulsion, double vision, loss of consciousness, etc. So if you see the red flags, so you can see, yes, remove from play. And then if no red flags, we kind of work through the rest of the steps. So the rest of the steps. So step 1, we have the observable signs. And so a bunch of yes, no questions for them to fill out. I will say this does exist in paper copies, but most of the time athletic trainers are familiar with this, that they kind of go through these things without you needing a paper to like guide them. So observable signs, Glasgow Coma Scale, cervical spine assessment, coordination and ocular motor screen, and then a memory assessment. And so if you notice, the memory assessment is very like sports oriented. So what venue are we at today? Which half is it? Or which quarter, if it's a sport played in quarters, who scored last, those things. There's also, so that's kind of the quick initial on-field assessment. Then we get to the longer off-field assessment. This is more likely to happen after the game. at halftime if it happened in the first half of the game. And this is where I said there was a much longer symptom list. So these are all the symptoms that the Amsterdam Consensus Statement associates with concussions. And so first step is, do they have these? And then they rate them. And so 0, obviously, if you don't have it. And then if you do have the symptoms, 1 through 5. And so you add all that up, you add up both the total number of symptoms and also the severity of the symptoms based on that 1 through 5 answer. And then we keep moving. There is the more familiar cognitive screening. So what month is it? What is the date today, etc. And then we have a word list. This was one of the changes from the SCAT 5 to the SCAT 6. It used to be 5 words. They did extend that to 10 words based on the studies that 5 words was maybe not capturing well enough whether people remember it. And so basically what you do is you give them all 10 words, and then you ask them to repeat them, and then you give them all 10 words again, and then you ask them to repeat them, and then you give them all 10 words again, and you ask them to repeat them. Sometimes people are familiar with a word list, so they give you alternate word lists to use. And then you tell them that you're probably going to ask them about the words at the end of the assessment as well. This next part is the digits backwards. And so again, they provide lists for you, so you don't, the trainer, or if you're doing it yourself, you don't have to come up with the numbers that you're going to use. And so you give them a series of numbers, and then you ask them to repeat the words. And this is for concentration. The other part of this is you ask them to give you the months in reverse order. So, and then we have coordination and balance exam. I will say this one can be difficult because sometimes people just don't have great balance. And if you don't know their baseline, it can be tricky to assess this. And so at the college level, we do get baseline before the season. So we have baseline of every athlete. But, you know, at the high school and middle school level, that may not necessarily exist, but you can still make a good determination using all the rest of this assessment. And then a place to put some comments on coordination and balance, delayed recall. So this is asking them about those 10 words again, and then giving kind of the final scoring there. And so this is the decision. I will say most people, like I said, don't, use this whole form box by box, but it is a good guidance, especially for newer trainers or newer physicians. And so that's the SCAT 6. I did want to also point out that this is for older athletes. There's a child SCAT 6 for like middle school and younger. Some of the things are a little bit easier because they're younger. So, but I didn't want to have to go through both of those. That would be a lot of slides. So next is reevaluate. So that's our next R. So you want to continuously assess the athlete's condition. And so if you're doing this at a primary care clinic, so this is typically where a doctor would take over if all the first steps were handled by athletic trainer. Follow up in the clinic. We'll go over a form for that as well. And then also making sure that you do have regular follow-up with the patient or athlete. So this was completely new. So there's the Scope 6 now, and it's the Sports Concussion Office Assessment Tool. And there is a child version of this as well. Again, I've kind of like tried to break it up into slides. It's very little on here, sorry. And so the beginning is kind of like history. And so, I mean, as a physician, you're going to take a history anyway. So I'm not quite sure you need boxes to tell you to do that, but make sure you take a history. There's family history included there. And then we also have symptoms and continuation of the symptoms. Again, you're asking for ratings here on how severe they are. And you could compare this to what, if you have the access to the one that was done on the sideline or at halftime or after the game, you can compare those symptoms. So, and see if there's improvement, worsening, and that can guide you as well. Again, a lot of it is similar. So there's the word recall, as well as the digits backwards and the months backwards. A lot of this is just so you can compare, because concussions, people tend to not to like to see them because it's kind of like they feel it's ambiguous on like, how do we diagnose it? How do we know that it's a concussion? And so giving all this data really helps guide your management. And so you continue here, cervical spine. And so, we're doing a physical exam, which I would assume most people would do, neurologic exam, balance again, same caveat there. If you don't know their balance baseline, this might be harder to use in your assessment. And then this is continued balance. So tandem gait, dual gait, and then this is the VOMs. So I do have some slides explaining what this is. There was not a overwhelming consensus that the VOMs needed to be done per the Amsterdam Consensus Statement, but I will say in my practice, I do use it. So I did want to go over it. And I like it because it is a little bit more like measurable on our end. There are like specific exam findings you can look for. It's not just asking someone if they have symptoms, because let's say they're like very motivated to go back. Oh yeah, no, I don't have any symptoms. But you can't really trick this exam in my experience. And so it's vestibular ocular motor screening. And so I've included pictures. So first you start with smooth pursuits. So you're just asking them to follow your finger, both horizontal and vertical. You can ask them if this reproduces any symptoms. That's one way that this can be considered positive. Another way that it can be considered positive is you actually watch their eyes. If their eyes are not moving like smoothly from side to side and up and down, let's say very jumpy, or maybe they're kind of like rolling through the bottom or rolling along the side to get up and down, side to side. Those are concerns that, concussion symptoms could still be happening and it'd be affecting their vestibular system. Next is vestibular ocular reflex. And so on this one, you don't move, but the patient moves. And so you would hold like a pen. Oh, here we go. You would hold a pen and you would ask them to focus on it and turn their head side to side, keep their eyes focused on the pen and move their head side to side and then up and down. And that's another one. Ask about symptoms, watch their eye movement, see if there's anything concerning. A lot of times I've seen with people that are very recently post-concussion, there's like blinking, they're like, it's hurting their eyes and they're blinking to try to help with that. So, and then this is saccades. You do it again, horizontal and vertical. So you have them look from finger to finger horizontally. You have them look for finger to finger vertically. Look for similar things as mentioned on the other two. Ask for symptoms, look for abnormal eye movements that can guide you. This one, sometimes I leave out if it's pretty early post-concussion because they can get kind of dizzy and they're standing and I don't want them to fall. And so basically you have them hold their thumb out in front of them and then they focus their eyes on their thumb, but turn their body. And I guess about 50 beats per minute is the recommendation there. And that's the visual motion sensitivity test. But like I said, if it's very early post-concussion, this could make them quite dizzy. So if you are going to have them do it, make sure you're in a position to, catch them if they start to lean. And so this is most of the VOMS testing. And so these are the things that I do. Yep. Oh, the symptoms. Yeah. Symptoms, they become unsteady, things like that. And then mental health conditions can complicate recovery from concussions. And so doing a screening on that is recommended as well. So we have anxiety, depression, and sleep. Not getting good enough rest can also delay your recovery. And so you want to make sure that those things aren't present and possibly complicating the recovery. And then again, you ask them the 10 words at the end of everything, and that's the delayed recall. The next R was rest and exercise. So it's an initial period of rest, and then but it's not full strict rest for very long, because they did find out that strict rest is actually counterproductive. And so some light activities are encouraged. And then you want to do gradual reintroduction to physical activity. Referral, this one's pretty simple. If symptoms persist beyond 4 weeks, you want to consider referring out to a specialist, whether that is a sports medicine physician or a neurologist. Yes.
What are they gonna do differently?
So I guess we can also refer. And so the vestibular screening, if it's not something you're comfortable with, we have vestibular therapists that we use with our athletes. We would try to get them in with a more extensive screening for those that aren't comfortable. But if you are very comfortable and you feel like you've done everything, then probably sports neurology is where I would go. The UT did just add a sports neurologist who's very interested in concussions. And so that is a resource that's available. And like it says on here, multidisciplinary approach usually yields the best outcomes. So rehab, this is where I kind of have some slides that talk about vestibular rehab. So persistent symptoms such as dizziness, neck pain, and headaches lasting for more than 10 days, cervico-vestibular rehab. Symptoms persist beyond 4 weeks for children and adolescents. Active rehab and multidisciplinary collaborative care can be beneficial. And for those with dizziness or balance problems, perhaps just vestibular versus cervico-vestibular. Don't worry, I have a slide on it. And then regular assessment and reevaluation while they're in rehab is also important. So here's the main difference. So vestibular rehab is going to focus mainly on the vestibular system, and it's going to be about balance and spatial orientation, things like that. Whereas cervico-vestibular rehab involves more of the neck and the vestibular system. I mean, it's in the name, but I put a slide just in case, and it kind of goes over what they do. So techniques in vestibular, exercises to promote central nervous system adaptation, and then for cervico-vestibular, they involve some neck-specific exercises, maybe manual therapy. Also will likely include the things from vestibular rehab itself. Recovery. So primary recovery outcomes, symptom ratings, clinical tests, functional domains such as return to learn, return to sport. There are 3 components they highlighted in the report: symptom reports, functional outcomes, and the return outcomes. So and then the next R's are return to sport and return to learn. So the graduated return approach is what most places use now. It is a 6-step process, with the first step being basically their normal daily activities. And at step 2, they can start to incorporate aerobic exercise. And then we go to sports-specific exercises, non-contact training drills, full practice, and then return to sport. In order to go from step to step, you do need to be symptom-free, and trying to do the exercises that are specific to that step should not cause a return of symptoms. And once you're back to full participation, you should definitely have no symptoms. So one of the other things that I think sometimes gets missed is return to learn. So it's not only hard to play sports with a concussion, it's also hard to pay attention in class, to take tests, to do homework. So if you do see people in clinic, I would probably try to send something with them that they can take to their school. And this is the current recommendation. So daily activities, and then school part-time, school full-time. And so I did recently have to work one of my patients through this as well. And, you don't want them to struggle in school because of the concussion. So their grades are just as important as athletic performance, right? And then reconsider the next R. This is where they kind of start to talk about maybe next steps. So looking at the potential long-term effects associated with multiple concussions, increasing the societal concern, and then looking into the symptoms that happen later in life. So, you know, with like high school students, you may not see the mental health issues that happen later in life, but as I think everyone's seen in the news, former professional athletes do have that higher mortality rate. We see a lot of like suicides and things like that. And you know, when they look at it, it's like they had a lot of concussions. And so definitely things that we want to be aware of. Create awareness around persistent symptoms, and then the importance of shared decision making. Another R is retire. Obviously, the thing that we don't want to do, but this is saying that maybe we've had so many concussions and we're having such issues after these concussions that continuing to play the sport is not the best idea. And you know, we're physicians, so we're worried about the athlete's welfare. We do want them to play the sport, but we also want them to be healthy, right? And so sometimes the best decision is to step away, but it is definitely a hard discussion to have, and it should probably not be done lightly. So,
So they said multiples. Could you be a little more quantitative about that? I mean, you implied that someone has to do with the sequelae
Yeah.
afterwards.
Yeah.
So what, can you give us any guidelines on that?
We don't really have specific numbers, and it also is really like how well they recover, and also perhaps the duration between concussions. You know, maybe like 4 in a few years is not a great number, but let's say they've had 4 since they started like playing this sport in middle school, and now they're a professional athlete. Like, so that time component also plays a part. So yeah, maybe in the next consensus statement. And then refine, again, this is them talking about next steps. So they did ask people what they felt was like members of the conference attendees, what they thought would be their top 5 priorities for future statements. And so potential long-term effects and prevention and rehabilitation seem to be the top 3 there. And so likely they're going to use this to guide the decision, what they focus on in the future. So conclusions, it tries to provide a structure to the diagnosis and care of concussions, as there continues to be variations in practice. And then despite being a focus of extensive research, and now I think even like more media coverage, things like that, the understanding of concussions still is pretty uncertain. And there's differences in symptoms, there's individual responses to injury, the complexity of the recovery. So it is hard to make a standard protocol, but this statement is trying to do its best to make somewhat of a standard protocol that people could follow. And there's a continued need for ongoing education, awareness in sports communities. And so you probably don't see this at the higher level. Like, I think most of our athletes at UTSA are pretty well aware of concussions, the whole medical staff there. It's something we talk about frequently. But, you know, small high schools, more rural schools, this might be stuff that is less well known. So, and then these are the references. And then I have a question slide. I will point out, because I like the picture. So that's me, and then Sam Baginski, who's also a graduate of here, and then Neil Sood, who's y'all's academic chief. And so UTSA played UIW in August, and we were the 3 doctors on the sideline, and we're all from this program, which I think is very cool. So
A little more of your experience with the group of people who have like symptoms 4 weeks out. I mean, I think that's not super rare. I've seen that, but I don't think it's super common either. What's the prognosis and how common is that?
yeah, so with those, I mean, I would say it's not very common. I definitely saw it more in fellowship than in recent practice. And part of that was we were doing these Saturday clinics where we were like 60 athletes coming. And so there was just a high volume of concussions that came to those. And so a lot of times that is where we stepped in with the vestibular rehab. Vestibular rehab, it's a specialty through physical therapy. And so there is, I think we just have one at UT, Barry Morgan. And so they really do a good job of working with the athletes on like rehabbing the vestibular symptom or system. And a lot of times that does improve those long-term outcomes. I haven't had to refer anyone to neurology, but I do plan on, his name is Dr. Meyer Patel. So I do plan on, meeting with him, kind of figuring out a pathway for that as well.
Have you seen it where it like goes on for like 12 weeks, 6 months, that sort of thing? I've not.
I definitely can think of one case where I saw that, but we had some concern for some underlying mental health with that athlete as well. And that was why, on the SCOAT 6, they do have that mental health screening, like whether he had some underlying depression, anxiety that could have been complicating that recovery. And at that point, we tend to send back to the primary care physician to see if we can get those symptoms better managed and see if that improves the symptoms they're reporting for concussion.
The SCOUT 6 seems pretty comprehensive.
Yeah.
So I'm wondering, if we have someone coming to clinic,
Yeah.
what is the viability of doing the entire thing?
Yeah.
Is there an abbreviated version?
There's not. I will say, I think on the slide, it seems longer than what I think it would actually take you to do in practice, because some of those slides were gathering a history. Like that's part of the visit. Checking the neck, you're going to check the neck. Family history, it's probably already in the chart if it's a established patient to you. So there's not really an abbreviated. There are things you can do to kind of like help the visit progress quicker by, like, if it's a concussion, maybe you print out that symptom scoring sheet and have them like fill it out while they're in the waiting room. And so that's one of the things I do. I'm like, oh, this is a concussion print, and then they bring it in and I can review it that way. That way we're not sitting in the room and I'm saying like dizziness 0 through 6, so stuff like that will help too. Oh, yes.
What are your thoughts on the pre-concussion baseline test?
So I think they're great. I don't know that they're feasible for the entire sport playing population. So at UTSA, we can do it. It's very easy. That's a controlled group of athletes. We just have them do, and we use, there's so many different types of baseline testing. We use one called Sway. And so we'll do a baseline Sway testing at the beginning of the season, just as a part of their like intake physical. And I do find it very helpful, but to get every high school athlete to do that, it's probably difficult. So. Usually 2 weeks, unless I'm more concerned, and then I do 1 week. So more concern would be like high symptoms or the severity of the injury. So. Any other questions?
I have a question, but I'm online. Are you there? Can you hear me?
Yep.
Oh, we had a curious case that was a little bit different. A patient who, in what we called a concussion after break dancing repeatedly for several weeks or several days, and then came in, had symptoms, mostly photophobia and like difficulty watching TV and some headaches and whatnot. Came back like a week later, still had the symptoms, and was having difficulty getting headaches while looking at the computer screen. But he doesn't have any of the dizziness, nausea, vomiting, the other symptoms, but still the sensitivity to the screen.
Yeah. Did he do any VOMS testing or?
No.
Okay. Yeah. So that looking at the screen, if that's what's like triggering the symptoms, like my concern would probably be like the vestibular ocular system. And so I'd be curious how those tests or what symptoms those tests show on him. And if they were positive, like that would definitely be someone I'd consider the rehab referral for.
Okay. Okay. Thanks.
No problem. Yep, vestibular.
So is that, I mean, we send people for vestibular rehab for other reasons, but is it the same kind of thing? We send them to PT, or is it only specific people that do this fancy vestibular rehab?
No. It is the people in PT. Yeah, so my clinic is located at Kyle Seal Parkway, the UT Health building there. Within the audiology department, they also now have a like specialized vestibular testing machine. And so it's not treatment, but it can give us a little bit more data there as well. So I've been talking with them too, but those are definitely things that you can send the typical patient for or an athlete. So.
I noticed one of the question forms, I guess the history form talked about, you ask them about migraines. I mean, is that just baseline so you know about their headache history?
Yeah.
Or because I've never seen a relationship between trauma and migraine.
No, yeah, it's just so the headache history. So like obviously someone with migraines, they might have headaches at baseline that they're going to report. So
Yeah.
Any other questions? Continuation from this talk? Oh, sorry. Yep, sorry. My head first thought Raj, but yeah. I'm not sure, but I can definitely talk to him and yep. Yeah, I could talk to him and see what he would feel might be relevant for this talk. We do plan to talk soon, so I'll just add it to our list. So. I know. Yeah, I'll ask him and then I'll let you know. You got it.
The child gets knocked out. You tell him he shouldn't do that anymore. What do you do? The child, the family comes in and says, my child had a concussion. Do they continue to do that sport or should they stop it?
In terms of should they continue to do it during their life or I mean, concussions are a part of sports. And so, I mean, if it's a single concussion and it happens, and they're recovering and everything is going along the pathway that we expect for concussions, I'm probably not going to tell them to stop the sport. You know, there's a lot of injuries that happen from sports, and my like least favorite thing to do is tell a kid that, you know, it's something they're passionate about that they can't do it anymore. So that was similar to Dr. Nato's question. We don't really have a specific number that we count. So no, it's case by case. So I would take it, like I said, there's because that's basically that R that was retired. And so that's definitely a complicated decision that you want to do in the setting of like a family meeting and taking into context the concussions that preceded that and how their recoveries were and are they still having symptoms. And so yeah, it's much like it was somewhere on the conclusion slide. Concussions remain to not be like a cut and dry thing. So there's a lot of medical decision making that needs to be made by the doctor. So and with the family in agreement. So anything else? I think we have 5 minutes, but I can also stop. All right. Bye. Oh yeah, no problem.